start it now. And we can edit this, by the way. So the purpose of it is this, Harold. What I'm trying to do is that I'm trying to interview various specialists in various areas that I particularly work with to essentially disseminate good information directly to patients instead of through meetings and doctor-to-doctor stuff, and just speak a patient language like we talk to patients, and try to showcase how doctors collaborate. In this particular case with you, obviously, it's about Mohs surgery. And what the indications are, how plastic surgeons and dermatologists work together to do right patient care. Everybody stays, kind of experts in the areas that they work in, so that the patient ultimately benefits from best processes and, best practices, so to speak.
Okay.
So I'm going to moderate, I'm going to ask questions, and, you can just talk to me, talking to me, but let's try to keep it at a patient level.
Okay.
All right. Well, Dr. Rabinovitz, it's always a pleasure to talk to you in person, on the phone, via video, in Zoom in the COVID era. But, I respect you immensely, and you're a very, very dear friend of mine. And we worked together now for almost 10 years, taking care of skin cancer patients, melanoma patients here in South Florida, and really all over the world, because patients come see you from all over the place because of your background and your experience and expertise. So one of the things that I wanted to do with you today really is to, speak directly to patients, take this downtime and try to educate, and kind of bring some semblance of knowledge from experts in the field directly to patients versus filtered through marketing companies or meetings and whatnot, because this is the media that a lot of patients experience and enjoy. And I do a lot of this, and patients have given us a lot of positive feedback about these types of forums. So I thank you for joining this brief 30-minute discussion about Mohs surgery specifically, and as it relates to skin cancer.
It's my pleasure.
Well, Dr. Rabinovitz, the first question really that I want to ask you is that could you really describe to an average patient what Mohs surgery actually is, so that we can demystify Mohs surgery?
Sure. But before doing that, you need to have a little background on skin cancers. And essentially, there are three types of skin cancers: basal cell carcinoma, squamous cell carcinoma, and melanoma. Melanomas are the most serious because they can be potentially life-threatening. Basal cell carcinoma and squamous cell carcinoma are predominantly due to light exposure, as well as there are other risk factors. Skin cancers of the basal cell and squamous cell variety can be treated many ways. They can be simply scraped and burned off, and the cure rate's anywhere from 90 to 95%. They can be surgically excised, and when you surgically excise a skin cancer, you take a margin and you send it to the pathologist to make sure that the margin's clear. Skin cancers can have radiation therapy, so there are many different ways that we approach skin cancers depending on where they're located and the potential aggressiveness of the skin cancer. Another way that we manage skin cancers is with a method which is known as Mohs micrographic surgery. Mohs micrographic surgery is a method where the physician anesthetizes the area, outlines the area that needs to be removed. Once that is performed, a layer of tissue is taken. When the tissue is removed, it's excised, and when it's excised as a pancake. It's excised so that we can look at the entire skinage and undersurface. So when we excise the tissue, we take that tissue, we flip it over, we cut it into smaller pieces. We number each piece of tissue and make slides of the tissue looking at the entire skinage and undersurface. We dye the undersurface with two different colors so that we have the orientation, and we have a corresponding map which outlines the area that's removed. Once that is performed, the tissue is taken to the lab. It's taken to a histotech who freezes the tissue and makes slides of the tissue looking at the entire skin edge and undersurface. Then the Mohs surgeon takes the tissue which its slides have been made and looks at it underneath a microscope. Because we know the orientation in terms of the undersurface with the two different dyes, we know the exact orientation in terms of mapping these skin cancers out. So we then look underneath the microscope, and we're only looking at the entire skin edge and undersurface. We're not looking at anything other than that particular area. Say we saw some bad cells along the skin edge. Well, we would color that on the map, and we would need to go back to that area and go a little wider. Or say there were some cells in depth, we would go deeper. And we continue to do this till we get the area free. The surgery normally takes about 5 or 10 minutes. It takes about 45 minutes to an hour to process the tissue. If it's clear, we're done. But if it's positive, we go back to those areas until we get the area clear. The beauty of the method is threefold. One, it has the best chance to cure the skin cancer. It curates approximately anywhere from 98 to 95%, as opposed to conventional methods where the cure rate's anywhere from 90 to 95%. Number two, we trace these to the roots. And finally, we try to preserve as much normal tissue as possible. After the surgery is over, there's a defect. How large, how wide, how deep depends on how much we find. And then a decision needs to be made. Do we refer this to one of the plastic surgeons who we work with, one of the oculoplastic surgeons, or do we immediately repair the defect ourselves? And these are judgment issues, and judgment issues, always we look in the best interest of the patient.
So as a summary, so there's 3 types of skin cancer: basal cell cancer. A lot of folks I find have a difficult time remembering the second one, or pronouncing it. It's called squamous cell cancer and melanoma. So just to summarize again, basal is the most common type. Squamous is perhaps the second most common type, and squamous may be slightly more aggressive than basal. And melanoma, of course, is the worst type that you're talking about. And melanomas, can Mohs surgery techniques be utilized for all 3 types of cancers? Or in your opinion, what is the best indication for those 3 types?
So Mohs surgery can be used for all 3 different types of skin cancers, but there are limitations when utilizing it for the management of melanomas. For basal cells and squamous cells, there are indications. Some of those indications depend on where the skin cancer is located. It depends also on the pathology aggressiveness. For basal cell carcinomas, the indications for surgery are what are called the high-risk areas. These include the eyes, the nose, the ears, the infraorbital areas, as well as the lips and the retroauricular areas, which are behind your ear. So those are the indications for Mohs surgery. If it's a
So let's go through that again, Harold, if you don't mind. So the indications are one at a time so that the patients can hear exactly.
eyes, nose, lips, ears, temples. These are considered the high-risk areas for primary basal cell carcinoma. That's one indication. The second indication is size. If a skin cancer is greater than 1 centimeter on the face, irrespective of where it is, it's an indication. The aggressiveness of the tumor. Some basal cells are very superficial in the skin. Others can be very, very infiltrative. For an infiltrative basal cell carcinoma, this is another indication to do Mohs surgery. And finally, in addition to those, most skin cancers are cured, as I mentioned before, anywhere from 90 to 95% of the time. When a skin cancer occurs in the area that was previously treated, we don't like to simply scrape and burn it off because there's scar tissue. And this is another indication to do Mohs surgery. Now, these are the indications for basal cell carcinoma. Squamous cell carcinomas have the same indications, as well as perhaps 1 or 2 more. These include the fact that squamous cells, if they are infiltrating the skin, can be potentially quite aggressive.
When you say infiltrating the skin, Dr. Rabinovitz, when you say infiltrating, do you mean it's going deep into the skin, or do you mean it's coming out of the skin?
So when we talk about it infiltrating the skin, we're talking about it going deep into the skin, not on the surface of the skin. And some squamous cell carcinomas can go into the glands. They can travel along nerves. So we have a little more respect in terms of how we manage squamous cell carcinomas as opposed to basal cells with the conventional modalities. Now, regarding melanomas, melanomas is a recent indication to do Mohs surgery. Melanomas are indicated for melanomas on sun-damaged skin or melanomas less than 0.6 millimeters. This can be on any area of the body, and the cure rates are quite successful. The patient has a melanoma which is going very deep in the skin. Most surgeons will refer these to one of the surgical oncologists or one of the plastic surgeons who has experience in managing melanoma.
Okay. Well, a common question that people, at least ask me when they come to see me as a plastic surgeon is, well, how big is my hole going to be, or how much is going to be removed? And it's something that, is there a way that you particularly explain to patients simplistically so they can understand before they get into something?
Well, so first of all, it depends on the size of the skin cancer. So if the patient has a large skin cancer to begin with, the likelihood that this is going to be a larger defect is much greater. Second, if the patient has a pathology which tends to be aggressive, these defects tend to be much larger as well. So we discuss this with the patients beforehand. We discuss the fact that they have a potentially aggressive skin cancer, and we try to explain to them that we don't know for sure, but the defect might be larger in these types of situations. And then there are areas where the skin cancer is located. For example, in areas right here in the corner or behind the ear, these skin cancers go well beyond the margins of what our eye can see. In those instances as well, we have an idea to explain them of what the potential outcome might be in terms of their defect.
Well, so how does an average patient who never, heard about this or is facing it for the first time, optimally prepare for such a surgery? Because certainly in offices like mine, we see patients, maybe, a little bit anxious, and I'm sure in your office as well. They don't know what to expect or how extensive it's going to be. So how does one best prepare mentally and physically and logistically for something like this?
Well, we educate them. We explain the method, we explain it in detail, and we explain it to them once they're prior to the surgery as well. We try to answer all their questions to allay their fears, but they have a cancer which potentially can be devastating. And we try to explain that to the patient as well. There are unknowns, but for the most part, 98% of the patients feel comfortable having the procedure once it's been explained to them. And for those that can't be comfortable, those individuals might choose perhaps another modality in having it managed. And that's okay.
So again, in your vast experience, what types of skin cancer procedures do you recommend to be done by the Mohs methodology? And when do you use your judgment to say this is something that should be done in another environment or another setting?
So let's talk about each one of these skin cancers. Well, let's talk about just basal cell and squamous cell because that's the majority. So for basal cell carcinomas, 98% of the tumors where Mohs surgery is an indication can have the procedure. There are some individuals who are compromised regarding their health. That has to be taken into consideration. There are certain drugs that individuals are on which can cause excessive bleeding. That needs to be put into consideration as well. And when patients come into the office, we take their blood pressure because if their blood pressure is out of control, they can't have the surgery. And if we can't get it under control, this is another indication for this patient to be done in a more controlled environment. If the skin cancers are in areas which are, or if the skin cancer is so large and the patient has difficulty being done in an office setting, these patients are better done in a controlled setting as well, being sedated. The overwhelming majority of basal cells, however, can be treated in an office setting by a Mohs surgeon. Now, squamous cells is a slightly different story. Squamous cells, the majority of squamous cells can be treated by Mohs surgery, but if the patient has a very aggressive squamous cell carcinoma, which is going deep in the skin, where there's a potential for them to lose nerves, or there's a potential to hit structures which are imperative that they be done in a more controlled setting. These individuals as well should be done at an outpatient surgery center or in a surgical office which has the ability to manage these type of problems.
So you know, in your practice, how many different types of physician colleagues do you generally work with on a day-to-day basis, and what kind of physicians do you work with?
So the overwhelming majority of my patients have always been referred by dermatologists, plastic surgeons, occasionally some surgical oncologists, and that's the majority of patients who are referred to me. Occasionally we'll get a patient who wants to come for a second opinion, or occasionally we'll get a patient referred by one of the primary care physicians, but the overwhelming majority of my patients are referred from either dermatologists, plastic surgeons, or surgical oncologists.
And what type of physicians do you refer patients to collaborate with you to take care of these patients?
So I always believed in multidisciplinary approach to managing patients. So I work very, very closely with the plastic surgeons like yourself, and I work very, very closely with the oculoplastic surgeons. Those are the two surgical specialists that I tend to work with. There are times as well that I will work with the head and neck surgical oncologist, but for the most part, if they need a head and neck surgical oncologist, we refer the patient to be done by him completely in a more controlled setting.
And you know, do you believe that many of these, you know, again, just to talk about the more common variety, the basal cell and squamous cell cancers, do you think many of them will need any consultations or second opinions from an oncology doctor who does radiation or chemotherapy, or is that not necessary for most patients?
So for most basal cell carcinomas, Mohs surgery is often considered the treatment of choice. There are selective individuals and in selective areas where radiation therapy is a good alternative. Radiation therapy's cure rates are anywhere from 93 to 96%. For our older patients, patients who are in their 70s and 80s, it's a good alternative. And basically we try to explain to the patient that these are the options that they have, either Mohs surgery or radiation therapy, depending on their health, and depending on other situations as well. The ears are another area where radiation therapy is quite effective. But for the most part, other than those two areas, unless the patient would like to have an alternative option, Mohs surgery is always, in my opinion, the best way to go.
So all things, you know, considered equal, if you had a skin cancer of the basal cell or the squamous cell variety, in you particularly, I'm asking as a hypothetical situation, which modality would you choose for yourself?
Depends on the location. If it was on my arm, I'd scrape and burn it off. If it was on my face, I would do Mohs surgery if it met the indications.
Again, let's go over the indications one more time, Harold, so we just make sure that everybody understands. You talked about the eye area.
Eye, nose,
lips,
ears,
and the temple.
And the central portion of the face.
Okay. And you know, do you believe that, you know, across the country, across South Florida where we live, do you think Mohs surgery is being done, you know, do people know about it enough? It's underutilized, overutilized? Is it optimally utilized? What have you seen in South Florida?
I think Mohs surgery has become the treatment of choice for dermatologists to refer their patients to for management of their patients who have skin cancers on the face. I think there is good understanding in this community as well as throughout the United States on the role of Mohs surgery.
So if someone had a skin cancer of the basal cell or the squamous cell varieties on the arm, shoulder, chest, back, you know, optimally, am I to understand that Mohs surgery is not necessarily the right choice, or in, you know, is that how would you do that?
Right. So let's talk about let's talk about basal cell carcinomas. If a basal cell carcinoma is less than 2 centimeters, Mohs surgery is not indicated. Okay. If it's an infiltrative basal cell carcinoma, it has an indication, but it certainly can be surgically excised as well. So for the majority of skin cancers on non-facial areas, these can be handled by either surgical excision or by scraping and burning them off. For squamous cell carcinomas, slightly different indications for Mohs surgery on non-facial areas are a little less stringent, and it's question mark in terms of for infiltrative or squamous cell carcinomas that are invasive. Mohs surgery is considered the treatment option. We do not do Mohs surgery on squamous cell carcinoma in situ. And a large percent of our squamous cell carcinomas are squamous cell carcinomas in situ on these non-facial areas, and those do not need Mohs surgery and is not an indication.
So again, to summarize, just so our audience understands, squamous cell carcinoma in situ is essentially a very shallow skin cancer that doesn't penetrate deep into the skin. And when it's not located on the face and the rest of the, and if it's located elsewhere, Mohs surgery is not indicated or not necessary. And it can be taken care of in multiple other ways, like you said, maybe scraping and burning it off or surgically removing it, and maybe in some cases, radiation is sick or.
There are other areas as well. I didn't talk about the periungual areas around the nail. It's an indication to do Mohs surgery for even superficial squamous cell carcinomas, in situ squamous cell carcinoma. So there are other indications, but there's a whole list. And basically, at this point in time, at least the majority of Mohs surgeons I know follow the indications very, very carefully.
So this is going to be our last question, and this is about the future, really, because of the situation that we all are experiencing. Do you see a role of doing surveillance and initial consultations and initial analysis of various types of things on the face or the body for skin conditions, especially specifically in this case skin cancers, remotely, virtually, like we're doing, like with teledermatology, what you call teledermoscopy, where you could do a lot of the preliminary work, without having to have rooms full of patients in dermatology offices and, kind of create better patient experiences?
So teledermatology is here to stay. Regarding neoplasms of the skin, one can see one isolated lesion and for the most part make a good judgment in terms of whether that patient needs to have that biopsy. But one can't give a full body skin exam with teledermatology at this moment in time, in my opinion. And these individuals who are high risk for skin cancers, such as patients who have hundreds of moles and are at the risk for melanoma, do need to be seen in a more controlled office setting. But for an isolated lesion, I believe that for the majority of these neoplasms, a judgment could be made in terms of whether the patient can leave it alone or it needs to be seen in a dermatologist's office for a biopsy. Now, you mentioned the word teledermoscopy. Dermatology, we normally see with our eye when we are trying to diagnose skin cancers. And our accuracy for some skin cancers is very, very high. But for trying to distinguish a melanoma from an atypical mole, which is a benign growth, the accuracy is about 60%, which is like going to Las Vegas to play blackjack. So we attach a little handheld microscope right to the iPhone now, and we can take a picture. And what that does is it allows us to see structures and patterns underneath the surface of the skin, which we cannot see with our eye. And by doing that, our accuracy goes from 60% to anywhere from 80 to 85%. Now, the problem with that is that the public does not have these little attachments. They become very, very cheap. In fact, they only cost about $90 now, which you can attach to the dermatoscope. And if a individual doesn't want to come into an office, they can buy one of these little attachments and send the images, and we can make a diagnosis with much greater accuracy.
So I think, it appears that, obviously the world is changing, the diagnostic capacities are improving, the indications are getting more defined, and certainly the outcomes are vastly better than they were several years ago. So I hope that you and I can, drill down a bit more deeper on these various topics as we go in the future, and kind of specifically talk about dermoscopy separately and what that means to a patient, basal cell separately, what it means to a patient, and try to see if we can do these online meetings on an ongoing basis. Dr. Rabinovitz, we appreciate you joining us and sharing some very valuable information to patients. And we'll post this on all of our outlets so that we can propagate good education to everybody, as we always talk about.
It's been a pleasure.
Have a great day. Thank you so much.
You too. Be safe.